Good evening to all the aspirants present here. We'll be starting with the session 2 of Neurology, which will be taken by Dr. Varun Pushkarna, sir. So you may take over. Thank you.
Yeah, thank you. Good evening, doctors. I must appreciate your effort to go in for EDIC preparation. So in EDIC, it is usually focused on decision making and going as per the present protocols worldwide, specifically as far as Europe is concerned. My style of teaching is a little different. I take up the questions, then I give you the heading under which the question is asked, although those kind of headings will not be declared in the examination. But just to keep your thought process going on in the right line of direction, I prefer letting you know that the question is based on which disease or which condition or what kind of decision making I'm expecting out of these questions. I would like you to participate in this class so that the more involvement means better outcomes as far as the class result is concerned. Baki, when you appear in the exam, you will have different level of confidence when you are prepared with discussions. The questions are everywhere, but the discussions, they are the most important part of the classes. So you can unmute your mic whenever you have to say. Otherwise, keep the mic unmuted, and we'll have a good discussion. Don't worry. We'll begin with this question on Guillain-Barré syndrome and its management. A 42-year-old man presents to the emergency department with progressive weakness in his legs for past 3 days. He had a diarrheal illness a week ago. Neurological examination shows areflexia and bilateral lower limb weakness. He is now developing shallow breathing. ABG shows a pH of 7.45, PaCO2 of 29 millimeters of mercury, PaO2 of 85 millimeters of mercury on room air. Now, which of the following is the most important next step in management? Number 1, start high-dose methylprednisolone. Number 2, obtain a contrast MRI spine. Number 3, begin IV immunoglobulin. Number 4, intubate and initiate mechanical ventilation. Number 5, start plasmapheresis and corticosteroids. So these are the options that are given to you. This is basically to check your wisdom on managing this patient. Although it has already been declared that this patient is a Guillain-Barré syndrome patient, but in the exam you will not get a hint like this. So you'll have to pick it up from the question where you can see that it is a progressive weakness in the legs for past 3 days, which started after a diarrheal illness. Presence of areflexia and bilateral lower limb weakness, which is ascending type and now involving respiratory parts, allowing shallow breathing, and the ABG showing a little hyperventilation, showing a CO2 of 29. So how the management will change?
I would intubate and initiate the mechanical ventilation given the time for IV immunoglobulin might take some time.
Okay. Anything else? What about
shallow breathing? Shallow breathing, intubate and ventilate.
So right now we have one answer that we have to start the intubation and initiate the ventilation. So if I have to just go through, I've already told you that this is a Guillain-Barré patient and we've discussed the diagnostic criteria. So in a patient of Guillain-Barré syndrome, just having a low CO2 levels, they are an indicator that the patient's respiratory muscles, they have started to feel the heat of situation. So right now they are blowing off carbon dioxide. Eventually they will retain it and then they will crash. So the first priority in the patient of Guillain-Barré syndrome is to assess whether they need intubation or not. So we always use a 20-30-40 rule. Anybody who has the idea of 20-30-40 rule? No? So we follow the 20-30-40 rule. So what is 20? 20 is the forced vital capacity less than 20 ml per kg. These are the criteria, threshold indicators for intubation. Okay. Negative inspiratory force of minus 30. Now these are the figures that you need to remember. Negative inspiratory force of less than minus 30 centimeters of water. It is calculated in water. And a total vital capacity of less than 15 ml per kg, and SpO2 target of less than 92%. Rapid progression, very important criteria. Rapid progression, that is, if somebody has deteriorated within 40 hours. So that is how you can remember that what you all have to see when the patient needs an intubation. So this rule, if you keep following, you can just answer these questions. So the patient who is showing respiratory muscle involvement is having tachypnea, low pH CO2, shallow breathing. This means this patient is soon going to have respiratory paralysis along with. So in GBS, early elective intubation, it is preferred. Why? Because if the patient crashes, and in that case, nothing else will help. If you can calculate, sorry, I forgot to mention the 40 here. Yeah. So that is peak expiratory flow of less than 40 liters per minute. So if that is there, then you have to intubate pretty early. IVIG, plasmapheresis, they always need time. They need time to start showing their effect. So eventually you will need them, but airway protection will always take up the precedence. Steroids, they are not beneficial alone in GBS. MRI spine is not going to help in this patient. Now, if I have to ask you, what would be the sequence of management in this patient? Can you tell me?
Yeah, first is the airway management, and then the initiation of immunoglobulin.
Okay. So how do you place immunoglobulins versus plasmapheresis?
We would give 5 doses first, and if it is not beneficial, then we can go ahead with plasmapheresis.
Okay. So let me tell you that there have been head-to-head trials of plasmapheresis versus IVIG therapy in case of Guillain-Barré syndrome. So the trials say that if you use IVIG, the chances of recovery are close to 30 to 35%. Similar is the percentage of plasmapheresis. And the data also goes on to say that if you combine both, that means IVIG and plasmapheresis combined, the outcome is close to 55% or maximum 60%. So some people, they utilize both of them together. Uh, it is either or. It is not one after the other. It is very important. Either you do IVIG or you do plasmapheresis. Both are equally effective. You can combine them, but it is not in a sequence that you do IVIG first and then you give plasmapheresis. People who are doing it, they are doing it just out of habit. Otherwise,